Yes, I think that works.
We did tutor for the child abuse lecture.
But he's like the average, the average, I like it. You know, well, listen, Psych is so many Psych is like no one when the fight but look at the guidelines that we were like oh you do really but like I got up really
Australia.
They found out.
No, why isn't it working?
What's happening?
I'm trying to get into it. There you go. All right. Okay, we'll make a start finally. Okay, everyone. So today we're doing paper 5. So a disclaimer at the start is apologies, I'm not as prepared as I was for last session. Not that I didn't have enough time, I just didn't use my time effectively to prepare. So hopefully it'll take, at the very least, it'll take a bit less time to go through the questions, okay? No, we'll make it 3 hours next time.
You know how to introduce yourself?
Okay, my name's Taha, right, I forgot. I'm a 5th year medical student, and today I'm gonna try and help you to revise with paper 5. So as we did last week, so questions are gonna be very in-depth. We're gonna use it as a revision tool rather than just answering MCQs, okay? So first question, what do you guys think? Oh, oops. What do you guys think is the answer? Okay, and why do you think that? Okay, so in that case, why? So given that he has a fever and he's difficult to walk, why couldn't it be something like transient synovitis? Sorry? Yeah, that's true. That's correct. So in the setting of any child who has had fevers, plus having fevers plus any joint problem is septic arthritis until proven otherwise, okay? So those are your 2 red flag symptoms. So high fever and a refusal to walk. So in that case, this is always septic arthritis is your red flag, and it's always septic arthritis until proven otherwise, okay? So if we would, let's do this one first. So what do you guys think of this one? Anyone? Okay, why do you guys think this is Osgood-Schlatter? What is it? What is that condition? No. So does anybody know the medical term for Osgood-Schlatter? So the other name for it is tibial. apophysis. Okay, so apophysis is just a word meaning protuberance. So this is a protuberance just under your tibia where your patellar tendon would insert. So a little protuberance there. So it's very common to have a very active an active person develop this kind of problem. Having localized and unilateral pain is a typical history of having Osgood-Schlatter's. So now let's talk about arthralgia and let's talk about limp because this is an important topic. So arthralgia and limp can be broken down into many different categories. For example, you could have inflammatory, you could have infectious, you could have mechanical, and you can have other causes. So other causes are things like, for example, chronic regional pain syndrome, which doesn't really effectively fall under any of these other categories. So we're not going to go through all of the details, but we're going to highlight a few important things, okay? The first one is painful versus painless, okay? Painful. And in this case, we're talking about limp. So in the 1 to 3 year old age group, what would your differentials be? So 1 to 3 year old with a painful limp. Septic arthritis, definitely. What else? How about, okay, first our red flag conditions. What's another red flag condition? Well, that presents very similarly to septic arthritis. Also due to an infection. Yes, osteomyelitis. Okay. What else could fall under in this age group? So actually you said trauma, yeah, trauma. Okay, yeah, in some cases HSP. Okay. How about, okay, painless? So a limp in the painless. So it might be hard to see a little baby walking in the 1 to 3 year old age range. But let's say if they're crawling or if they're just starting to walk, what might be some conditions that are painless that can cause a limp? Yeah, very good. Yeah, so I'll just write decreased vitamin D. What else? What's a very common one that you have to test in the neonate? DDH, okay. So that can cause some problems with your hip. Yeah, so developmental dysplasia of the hip for everyone at home. And another common one is JIA. Okay, so JIA can present in many, many different ways. It can present with pain in some cases, but common presentation is a painless limp as well. Okay, how about if we now go to the 3 to 10 year old age group? I don't think so, no. So DDH is when you do autolinase and bolus tests. So that's usually due to, so that's usually due to having like oligohydramnios in the fetal period. So the growth causes some dysplasia or changes to the glenohumeral joint. Then that causes dysplasia of the hip where it clicks and it can't fully articulate properly. Sufis, we'll get to that. Okay, in the 3 to 10 year olds, what might you have? Not quite yet. Not really. Well, a 10-year-old maybe. Okay, but this is quite a wide range. So 3 to 10 year old. What else might you expect? So you can still have transient synovitis here. I forgot to mention you can also have it there. Transient synovitis is something that can go on all ages, right? Yeah, exactly. So still always your red flag differentials. Perthes is one that presents in these age groups, especially acute. Okay, and malignancy. So things like leukemia. So you can never rule out other malignant disorders. Okay. Then if it's painless, Perthes again, but in this setting is chronic. Okay. And then neuromuscular. So what is an example of a neuromuscular condition that can cause a limp? Duchenne's. Okay. So Duchenne's. Okay. And JIA again. So remember, like I said, it can span across the whole age range. And then I'll just cross out this one so that we can talk about older people. Well, yeah, definitely. Cerebral palsy could fall into these categories. 11 to 16. Okay. And in this case, what would you put here, Roland? Yeah. So septic arthritis, osteomyelitis. Yes, correct. But specifically SUFI. So SUFI is something that falls into this age category. Tumors again, JIA, and AVN. So AVN, what do you think would be a common cause of a child of this age to get avascular necrosis, especially of the femoral head? Steroids. And what's another thing that is associated with steroids? Cushing's. So one of the complications of Cushing's disease is to have avascular necrosis of the femoral heads. Okay. All right. And then in this case, you also have SUFI, but in this case, again, chronic. So the chronic version, JIA, and dysplasia. Okay. So this is just one way to think about it, is to break it down into painful and painless. Another important way is to think about the onset. So consider whether is it acute or chronic is also going to change what kind of differential you're going to get. Because, for example, something acute is more likely to be in a trauma or an infection, whereas something that's more likely to be chronic is, as we've mentioned here, SUFI, chronic SUFIs, Perthes, JA. These things are more likely to be chronic presentations. So also take that into account. All right. So erase all the slide. Okay. Now what we're going to do, we're going to quickly compare common causes of a limp. So septic arthritis, osteomyelitis, and transient synovitis. Okay. Now the first category we're going to talk about is age. I should probably put that a bit more. So what is the age for each of these? So septic arthritis, any age, but typically it's going to be someone young. So right, less than 2 years old. Okay. Osteomyelitis, again, it can be any age, but typically a little bit older, so we'll write about 5 years old. And then transient synovitis, again, any age, but we're 6 years old. So like what I'm trying to say is that this is more common is being younger is a risk factor for getting septic arthritis. Okay. All right. How about fevers? Are fevers present? And if so, how bad are they? Yep, high. Osteomyelitis?
Low grade?
Yep, low grade. And transient synovitis? None. Okay. How do they present? Oh no, not this again. How do they present? Anyone? So septic arthritis, a child looks toxic. They might have localized erythema. They're going to have decreased range of movement. They're going to have unwillingness to weight bear. Okay. This is going to be very similar. Okay. All right. And this one, recent illness. So recent virus. They're not sore ones. Okay. That's another important one. So rest pain. So they're going to have pain at rest. Whereas someone with osteomyelitis does not always have pain at rest. Okay. So typically with these two, you have pain with movement. Pain with moving. And with this one, you don't have pain with moving, okay, with transient synovitis.
It's only pain at rest, transient synovitis.
Oh, sorry, what am I saying? Sorry, you don't have pain with rest, but you do have pain with movement, okay? You also have stiffness, especially in the mornings, okay? You have some decrease of range of motion, especially with internal rotation. So might also have swelling. So there's a few key features that are going to try and help you differentiate between each of these common causes. All right. So what is the management for septic arthritis? If a baby if a young child presents to you and you feel that they have a high fever, that they're not willing to weight bear, that they're protecting the joint, you see some localized erythema, they cry out in pain when you feel over it, what is going to be your management? Which one? It does, but in general, what is your empirical therapy? Yes, so IV fluid clocks. What else do you need to do? So, like, again, imagine if you're in an OSCE station, how would you answer this question? How are you going to manage this child? So who are you going to refer to? Ortho. Okay, refer to orthopedics. Orthopedics always takes care of pediatric patients anyway, so you don't need to refer to pediatrics. Who else? What else are you going to do? So IV fluid clocks is your empirical therapy. If they're a neonate, then it's gentamicin. But what else are you going to do?
Only gentamicin.
Gentamicin and fluid clocks, I believe. Okay. So IV fluid clocks. What else? What else is the definitive management? They need aspiration. Okay. They need joint aspiration, plus minus, and arthrotomy. So an arthrotomy is when you make a small incision or a hole in the joint that allows you to remove foreign material from that area. Okay. So that's an arthrotomy, and then you need to immobilize them. So in ED, what you will be able to do is all of these things. You'll be able to do that, you'll be able to do that, and you'll be able to do that. So that's why in an OSCE setting, it's always important that you think about what kind of answer you're giving. Because a lot of people will just give the definitive management, which they'll say like aspiration and arthrotomy, which is not necessarily incorrect, but being able to differentiate yourself from your peers is going to be in your ability to answer that question effectively. Okay?
So the arthrotomy is just to train?
Yeah. So arthrotomy allows you to get access to that joint. Okay. Gentamicin. Oh, actually, for neonates, rather than flucose, I think it's gentamicin plus ceftriaxone. Yeah. Okay, so we'll go on to the next question. So this is a relatively simple question, and I'm not sure if we'll be able to go through all of asthma because it's quite a big topic, but regardless, does anybody know the answer to this? A mast cell stabilizer? Yes, montelukast. Maybe we'll just go through them. What's this? Me neither. Okay. Ipratropium? Yeah. This one? What's Maxelf?
Second last line.
Oh, does anybody know the mechanism? So, I can't remember either. Montelukast, so what did we say? Mast cells. I'm pretty sure this is something to do with the respiratory membrane or the cardiac membrane. Can't remember. Good. So we know that's a steroid. Salbutamol. Saba. Okay, good. Oops. Oh, whoops. Anticholinergic. We went through that one. Okay, so this is a topic that we'll spend a little bit of time on. So first, have a look at this question and let me know what you think. Okay, so we have a young girl. She's 3 years old. She has a recent history of weight loss. Okay, weight loss is typically always, I mean, in the absence of any other symptoms, that's always going to be one of your constitutional symptoms. Pallor and irritability. Periorbital ecchymosis. Okay, when you see periorbital ecchymosis, what comes to your mind? Yes. Okay. So what do we call that? What's that sign called in the basic skull? Recurrent eyes. So basilar skull fracture. What else? For recurrent eyes?
Yeah, you can get it. People are particularly small.
Okay, I'll add it on them. What else? So in the same instance, vomiting and coughing, we'll just add that together. Yeah, I couldn't imagine that to be specifically a recurrent eyes rash, but
It's not like recurrent eyes, but you do get periorbital.
okay.
Especially under the eyes, because you've got twin vessels, they tend to pop.
Yep.
Yeah. I don't think you could call it recurrent
Okay.
eyes.
So amyloidosis is another one. So amyloidosis is particularly from multiple myeloma. Okay. And another one is disseminated bacterial infection. Okay. So disseminated infection. So these are things that you need to be thinking of when you think of a periorbital ecchymosis. And she has bone pain. So all of these are quite concerning. So full blood examination reveals bone marrow suppression only. So how would a full blood examination tell you that there was bone marrow suppression? Yeah, so pancytopenia. Does that explain, therefore, why she has pallor and irritability? Yes. Okay. So what do you think she has? What's a carcinoid tumor? Yes. And where does that serotonin come from?
The tumor.
But where is the tumor?
You have it in a couple of places.
Yeah, so this is a GIT-derived tumor, so that's a neuroendocrine tumor. Is it an astrocytoma? No. She doesn't have any signs of? Yes, she doesn't have any signs of increased ICP. Is it a hepatoblastoma? Yeah, so unlikely in this case. A carcinoma? No. Neuroblastoma? Maybe. Non-Hodgkin's?
She said, what kind of kid gets non-Hodgkin?
Okay, so do people think it's non-Hodgkin's or not?
Yes.
Okay,
I thought it was A, but
Okay, so non-Hodgkin's can present in a few, well, non-Hodgkin's presents in two major ways, okay? So we'll talk about it. So either you have B cell or you have T cell, okay? So typically with B cells, you present with lymphadenopathy. So that is your typical feature for any non-Hodgkin's, especially in your ENT, so in your head and neck. For T cells, you have lymphadenopathy, especially in your chest. So in this case, it's unlikely that you're going to have malignancy or metastases to the bone that's going to cause bone marrow suppression and or bony pain. So it's unlikely in this case to be non-Hodgkin's. What's more likely is neuroblastoma, okay? Now we're going to talk about it. We're going to talk about it in detail. Did I not put a page? Oh, yes, okay, I did. Okay, before we go on to it, let's talk about this one. So 3-year-old, large irregular mass in the right upper quadrant on the routine examination. So that's an important part. This one was found incidentally. Okay, he has an elevated alpha fetoprotein. What do you guys think? Hepatoblastoma, for sure. Okay, so now we're going to talk about solid tumors. And we'll go through each of these. So the first one we'll go through is a Wilms tumor. Yo. Okay. The definition, epidemiology, symptoms associated with. We'll talk about Wilms. Guys, tell me, what are other solid tumors? Okay, before I write neuroendocrine tumors. So we have a hepatoblastoma. Is there anything else I should write? What's another one that we talk about? We talk about carcinoid. Okay, carcinoid. Okay, and then we'll talk about the neuroendocrine ones. Okay, so who can tell me what the definition of a Wilms tumor is?
Yeah, it's like a neuro network.
Yep. Okay. How common is it? So it's the most. Is it the most common tumor?
No, wait.
It's the most common renal tumor
Yeah, really.
in children. Okay. Definition. Epi symptoms. Okay. Now let's fill this table. Let's fill this in. Okay. So a Wilms tumor, importantly, is malignant. Okay. So it's a malignant renal peds tumor. So I'll just write tumor like that. It's the most common renal tumor. So most common renal tumor. So this, of all renal tumors, this forms 85%. Okay. However, as a total of all pediatric cancers, it only makes up 6%. So it's not particularly common as a pediatric cancer alone. Okay. But, and epi, so when does it occur? So typically, in your younger age groups, often found asymptomatically, but if it occurs as part of a syndrome, and we'll talk about what we mean by syndrome, then it's found earlier, okay, because it can present differently. So symptoms, what kind of symptoms do you get? Yeah, so specifically painless, upper quadrant mass, okay? So abdominal, there's a lot of things in the abdomen, so upper quadrant is something you need to specify, okay? What's another common thing they can present with? So if it's affecting your kidneys, you can get hematuria. So most often that's a microscopic hematuria rather than macroscopic, but it can also present macroscopically. Okay, so 80% of people who have Wilms tumor will have the mass and 20% will have the hematuria. Okay, and it's associated with specifically, I mean, most cases are sporadic, right? Most cases sporadic, but in some cases it is associated with. Can anyone finish the sentence? Yes, which one? Beck? Yes. Yep. Well, okay. Who knows what Beckwith-Wiedemann syndrome is? That's not incorrect. But there's a reason why Beckwith-Wiedemann is associated with a lot of things. Because what is this? What is Beckwith-Wiedemann at its simplest? So Beckwith-Wiedemann at its simplest is an overgrowth disorder. Okay? So you cause overgrowth. So overgrowth disorder. And it's present at birth. Okay? Present at birth. And the characteristics, so the reason that we worry about Beckwith-Wiedemann syndrome is because there's an increased risk of childhood cancer. So that includes hepatoblastoma and it includes a Wilms tumor, childhood cancer. However, 80% will not develop cancer, okay? That's why buzzwords are not good to live by. Okay, so we've kind of gone into that section, but let's now talk about neuroendocrine tumors. Okay, neuroendocrine tumors, where do they come from? So they arise from, yes, okay. So where would you find them commonly? So there's a reason why I guess medical students will always get you to compare between Wilms tumor and a neuroblastoma. Have you guys heard of the where people tell you the main differentiator is that a Wilms tumor is always unilateral, whereas a neuroblastoma can cross the midline? Have you guys heard of that? Okay, well, there's a reason we say that, because they're very comparable, because they both affect the kidney, right? So the adrenal glands are above the kidney, so it's in the kidney location. So arise from the neuroendocrine tissue, typically the adrenal glands. However, that can be at any location on the sympathetic cord. So typically your adrenal gland. All right, but it can arise from any part of the sympathetic chain, okay? So the important part about this, and to understand why a neuroendocrine, these tumors can cross the midline, is because they often extend past where they arise from. So the natural history of these neurotumors is that they extend typically behind the aorta, okay? So they extend upwards and they extend behind the aorta. And that is the reason why people with these tumors often present with things like hypertension, but that is also because they have increased catecholamines due to compression, and it's very common to have metastases as well. All right, and epidemiologically, this is the most common. So most common extracranial, okay? That's an important part, because the two most common pediatric cancers are leukemia and primary CNS tumors. So apart from that, these tumors are the most common. So the most common extracranial, and they're the third most common overall. Okay. Now, symptoms-wise. So again, this can present as part of a syndrome. And in this case, what did our girl have in that question? So we said it was a neuroblastoma, right? And she presented with specifically bone pain and bone marrow suppression. Now keep that in mind. So a neuroblastoma can present as part of a syndrome, okay? And there's many, many types of syndromes. One of those syndromes is called Hutchinson syndrome. You don't need to know this, I'm just letting you know so that things make sense. So Hutchinson syndrome. And in Hutchinson syndrome, the thing that characterizes it is the fact that you have bony metastases, okay? So there's many, many different syndromes that are associated with a neuroblastoma. So there's many things. Some of them are due to metastases other places. Some have eye symptoms. There's a lot of different ways that a neuroblastoma can present. Hutchinson syndrome specifically is due to bone marrow mets. So this is likely what this little girl has. Okay. So given that I've told you that it's a tumor that's arising from your adrenal gland, what investigation do you think would be important and would definitely be raised? Or I should rephrase that. What investigation is important? So very similar to so what is a pheochromocytoma? So it's also an adrenal tumor, especially of the medulla. It's very rare. But in both of these, what's the similarity between the pheochromocytoma and the neuroblastoma? In both cases, what is going to be raised? Catecholamines. And how do you measure that? So all of that is correct, but specifically you can do an MIBG, which is a specific type of scan. They use scintigraphy. I can't remember the word particularly, but that is how you assess for neuroendocrine tumor, as well as other things. So there's a lot of pathological factors as well. So there's like Homer-Wright rosettes or something. You can do CT scans that will also show you a tumor mass. Okay, so I'll have to rub a little bit of this out. We'll talk about. Oh no, it's frozen. Okay, so now we'll talk about carcinoid syndrome. Carcinoid syndrome is important. Okay, so what is carcinoid? What's the definition of a carcinoid syndrome? So this is a neuroendocrine tumor. Okay, so whereas Wilms was a renal tumor, neuroblastoma was an adrenal tumor, carcinoid is a neuroendocrine tumor. Okay, and where do the cells arise from? Does anybody know? So they arise from the enterochromaffin cells. Okay, and who knows where these cells are located? They're located within the GIT, and what do they synthesize? Serotonin. Now, all of this, you'll understand why I'm telling you all of this now, very soon. Okay, so epidemiologically, it's the most, all of these tumors are good at something. So carcinoid tumor is good at being the most common. Malignant tumor of the appendix, of all places. Okay, but it's very common to find these tumors anywhere in the small bowel, anywhere in small bowel. Okay, so jejunum, ileum, duodenum, any of those cases can have it. Okay, now the reason I told you about this is that a carcinoid tumor then becomes carcinoid syndrome. So tumor to syndrome, it becomes a syndrome when you have increased serotonin release. So what that serotonin release does is that it causes a few different symptoms. Okay, does anybody know what one of the classical symptoms is? Diarrhea. Okay, now diarrhea, it came up in the past exam questions, and if somebody has a carcinoid syndrome and they have diarrhea, what do you give them? You give them, yeah, metamycin or psyllium husk. So diarrhea, flushing, okay, peripheral edema. Yeah, but I'm just saying, okay, peripheral edema and cramps, okay, cramps and wheezing. So if a patient has any of these symptoms, this equals carcinoid syndrome. So it goes from just a carcinoid tumor then to a syndrome, and this only happens in 10%, okay? So 10% of people have a carcinoid tumor, have an increased serotonin release, and the serotonin release causes these symptoms, which is why it's important to understand the basics of a carcinoid tumor. I don't know, it's just related to the serotonin, apparently. All of these side effects are related to serotonin somehow or some way. Okay. All right. Okay. And the other thing, so the reason why this would definitely not be a good answer in this case is because typically the age of diagnosis is 63 years old. So definitely would have been a bit old for this question. All right. Make sense? Okay, good. All right, so those are solid. So we've talked about neuroblastoma. We've talked about Wilms tumor, which is a nephroblastoma. And we've talked about carcinoid syndrome. Now what's important to talk about, actually, we'll talk about that soon. There's a few more important things to talk about. So these are two CT scans, one's of Wilms tumor and one's of a neuroblastoma. So there's a few key things that on the imaging tells you that this is a Wilms tumor. Now, I'm not a radiologist, remember, I'm a medical student, so I don't know how to interpret this for sure. But one thing you do see with Wilms tumor is a claw sign. And apparently what a claw sign is that it allows you to identify whether the tumor is coming from within the organ or it's coming from outside of the organ. And apparently how it looks is you're supposed to have these sharp edges. Now, I don't know if that particularly is a claw sign, it might be, but that is the description of a claw sign, is having these sharp edges, and that tells you where the tumor is coming from. So I think that's a claw sign. Neuroendocrine tumor, it doesn't have anything particularly associated with it, but what you will notice is that if we put a line down the midline, what do you notice? Is that it's extending across. If I put a line down here, it doesn't. So it's only limited to this section, whereas this one is extending across. So that's why they say a nephroblastoma or Wilms tumor does not cross the midline, whereas a neuroblastoma does. Okay? All right. Next, very, very important thing that we need to talk about. What's this a picture of? All right.
Sorry, just coming back to the claw sign, the idea is showing that it's like coming from inside the organ, right? From like
something like that.
From inside the kidney.
I think so.
Okay, yeah.
That's relevant? I mean, do we need to know it?
No.
What's the origin of cells for the neuroblastoma?
Anything from the sympathetic chain.
Oh, right.
Yeah, neural crest cells. That's exactly correct, Hannah. Yes, neural crest cells. Sorry?
Is that why it crosses the liver? It's not like restricted.
It's not restricted to the kidney. Yeah, and like I told you, the natural history of a neuroblastoma, many things, but typically it can extend I mean, normally you see the aorta somewhere here, so it extends above and behind the aorta, and typically goes into like your neck and your ENT region. So it's very big. All right. So what is this? What is this section of the brain called, of the skull? Yes, posterior fossa is what I was trying to get at. Okay. So this is a posterior fossa. So what am I going to talk about? No. What's it more general? I'm going to be talking about posterior fossa tumors. Okay. Now in children, there are 4 common posterior fossa tumors. Okay. And you can remember them by this mnemonic, BEAM. Okay. So B is for brain. Can anyone finish these? Brainstem glioma. Okay. E is for ependymoma. Okay. A is for astrocytoma. And M is for? Yes, medulloblastoma. Huh? Yeah. Okay. So these are your common posterior fossa tumors in children, and all of them are very common. Okay, but we'll talk about, and by the way, this list is not in order of prevalence. So I should just write that for you now. Okay. Yes, well, yes, I said it incorrectly. Which one is the most common out of this list? So 85%. Now, this will not add up because these are all very wide ranges, and I've just given you one number. Okay, ependymoma, around 10%. A brainstem glioma, around 25%. Like I told you, the numbers do not add up. Okay, and a medulloblastoma. Yeah, they are. Yes. Okay, and as for the ages, okay, ages is another very important thing to know about. So a glioma presents generally around 9 years old, give or take. Okay, ependymoma is your young kids, so 3 years old. Astrocytoma within the first decade, so less than 10 years old. Okay, and the medulloblastoma within the second decade, so less than 19 years old. So we'll talk about each of these. All right. So just from looking at that, does anybody know what this is? Where is it located? It's in the brainstem. Okay, so this is a brainstem glioma. Okay, so again, we'll go through our list of definition, symptoms, and associated with. Okay, so definition. So this is a gliomal. So what are glial cells? Say again? Yes, exactly, supportive cells. So it's a tumor of the supportive cells. What symptoms do they present with? So given that we're affecting the brainstem specifically, they're very common to get CN palsies, okay? You can get ataxia because the long tracts are coming through this area. Okay, and yeah, sorry, long tract signs. So what do we mean when we say long tract signs? What does that mean? Okay, so having a long tract signs, this implies that you have some problem in the upper part, so problem of upper spinal tract, okay, of your upper spinal tract. And this is essentially where your spinal tract is beginning there. So this causes things like, so what are your upper tract signs, anybody? So you can have clonus. I miss all of what you said, sorry. So clonus, anything else? Muscle. Yeah, okay. Essentially. Muscle spasticity, you can have bladder involvement. So bladder involvement. Okay, so those are your long tracts. So those are the symptoms that are very common to get with a brainstem glioma. A CN palsy, ataxia, and your long tract signs. And it's associated with neurofibromatosis type 1. Okay. All right, so then this is our next one. Does anybody know what this is a picture of? So this is where our tumor is. Yes. Okay, why? Oops. Okay, so this is a medulloblastoma. So So why was I showing you that picture before? This one? So I was trying to show you this location. So what is this called? This is the fourth ventricle, okay? So the fourth ventricle is important because the medulloblastoma is, so again, we'll write the definition. So it's the most common. So it's the most common malignant tumor. So malignant, that's an important word, malignant brain tumor of childhood. Brain tumor of childhood. That's an important part to remember because it's malignant, okay? And it presents as a midline mass. So midline mass on the roof of the fourth ventricle. So does anybody remember what the fourth ventricle is? So yes, exactly. So that attaches the cerebral aqueduct to the orbix, which is another part that drains your CSF. So these are your lateral ventricles, right? Your lateral ventricle. Then I can't 100% remember, but then you have like the foramen of Magendie and the foramen of Luschka that allows it to drain. Then you go through, I'm pretty sure that's the third ventricle, right? That might be the aqueduct. And then you go into the fourth ventricle. So this is a tumor of the fourth ventricle. No. Okay, my bad then. All right. So what symptoms do you present with? So what will allow you to differentiate medulloblastoma from anything else on an exam is rapidity of onset. So the symptoms here are rapid in onset. Okay. Yes, exactly. So raised ICP and symptoms of hydrocephalus. Okay. So it's the onset, because everything else essentially presents with raised ICP, some things present with hydrocephalus. The thing that allows you to differentiate is the rapidity of onset. So typically within a few weeks, whereas other primary CNS tumors you might expect to have over months or years.
What about cerebellar signs? Does that matter?
I'm not sure. Okay. So another thing is that given we talked about the age that they present with. So any time within that age range, if you have a neonate that's presenting with a medulloblastoma, something that you can expect to see is potentially increasing head circumference because the cranial sutures have not yet fully aligned or sutured together. You can have expansion that causes an expanding head circumference. So rapidity of onset. So then this one, does anybody know what this one is? Yes, okay. So this is an astrocytoma. So there's a lot of different types of astrocytoma.
Sorry, is medulloblastoma associated with anything?
I'm not sure. Can't remember.
I thought I missed it.
All right. Astrocytoma. All right. So again, the definition, symptoms, associations. All right. So what is an astrocytoma? So it arises from the cerebellum, typically. So it arises from cerebellum. Cerebellum, isn't it? I think so, yes. Because these are...
I was saying last year, like the glioblastoma was from like the actual...
In adults, it's the
If it's the same.
the butterfly tumors.
Yeah.
Let us check.
Do you get astrocytes in the cerebellum?
Yeah, they tend to grow in the cerebellum.
There you
Okay. So at the very least, in the pediatric population, they arise from the cerebellum. Okay. Okay. So what kind of symptoms do you get? So again, predominantly increased ICP is your predominant symptom, but there is a triad that you might expect. Okay. One is the child might complain of morning headaches. Okay. The reason for that is particularly just because it's gravity fed. So morning headaches. Two is vomiting. Third is lethargy. So these are common, your triad of somebody who has increased ICP. They might also start with some vague symptoms. Okay, so vague, non-specific symptoms. So for example, fatigue. They might have decreasing academic performance. So I think these are all based on information from past MCQs. So increasing academic performance, might have some personality changes and such. Yeah. Pressure effect, I imagine. Okay. In an infant, so if you had an infant with these symptoms, then you'd have anorexia, so they wouldn't be eating, they'd be losing weight. You'd have irritability. You'd have developmental delay, and you might have regression. Okay. Then what is it associated with? It is very strongly associated with neurofibromatosis, number 1 again. So strongly. And when I say strongly, apparently 20% of people who have neurofibromatosis will develop some sort of CNS malignancy, and a high percentage of those is an astrocytoma. All right. Now the other thing is that depending on where you get the astrocytoma, 25% of them can present with seizures. So that's typically more likely for supratentorial astrocytoma. Just in a different location, you can present with seizures in those cases. All right. Then the last one, does anybody know what this is? Oh. Sorry, this is a medulloblastoma. Okay. They look very similar because both of them are related to the ventricles. So this was an ependymoma, and but what an ependymoma is a tumor of the lining of the fourth ventricle. Okay. Whereas a medulloblastoma arises from the fourth ventricle. So you can imagine why it's a bit difficult to pick apart. So we'll just pretend that this one is an ependymoma. We'll just talk about that. Ependymoma. All right. So
Wait, so what I'm confused. You're talking about a medulloblastoma.
So this is a medulloblastoma, but we're going to be talking about ependymoma. Okay. The reason I made the mistake is because both of them coming from the fourth ventricle. Okay. So ependymoma. All right. Again, so definition. So arising from the lining of the fourth ventricle. And symptoms, again, increased ICP. Okay. And you can get ataxia. And again, if it's supratentorial, then you can get a seizure. So the way that you differentiate it from something else, for example, how would you differentiate from medulloblastoma? From a medulloblastoma would be the age. So remember, these are people who are 3 years old, whereas somebody with a medulloblastoma is anyone within the first decade. So they might be a little bit older. Okay, and then last one, what is it associated with? Rather than neurofibromatosis type 1, this is neurofibromatosis type 2. Okay. I know it is a very big range, but something like 77 or 80% of people will present by that age. So I don't know if there's a particular age in which it is more common.
How is it going to be supratentorial if it arises from the lining of the fourth ventricle?
It can extend up there, I imagine.
We can just scroll up.
Okay. All right. All right. I guess we'll leave it there. All right. So that was a quick overview of primary CNS tumors and some common solid tumors, but there's a lot more solid tumors that affect children. Okay. So we'll go on to the next question. So we talked about it. What's Wilms tumor associated with? Beckwith. Okay. We'll talk about these other. I'm sure Kirby's probably gone through these other conditions with you guys. We'll go through them later. Okay. Duchenne's. So what is Duchenne's? Yeah. Okay. So it's an X-linked what? Recessive condition that affects abnormality in the production of dystrophin. Okay. So dystrophin, I can't remember what it is, but it's at the very least it's a gene related to your muscle production and your muscle strength. So people who have Duchenne's have this X-linked recessive disorder that doesn't allow them to develop the proper muscular strength. Okay. So what kind of symptoms does somebody with Duchenne's present with?
Cough.
What happens to the cough? Yes. So not actually hypertrophy, pseudo-hypertrophy, okay? The reason for that is because it's not the muscle that is gaining in size, it's rather the what? So it's replaced with fat, which is why it's called cough pseudo-hypertrophy. What else do you see? So if you ask them to stand up, you'll see what? You'll see Gower sign, which is when they use all fours to try and get up to a standing position. Okay, you might see some sort of waddling gait, or they might have falls. Okay, so they'll have difficulty walking is what I'm trying to get at. And most importantly, they're going to have progressive weakness. Okay, so this is why they don't present at birth, because they're going to have progressive weakness up until around the age of 3 or 4. So that's like when they'll be picked up, because the parents will come into your practice and they'll tell the GP, I'm really concerned about my child. They still haven't started walking. When they see them walking, they're grabbing onto the side rails and pulling themselves up. And then the GP will go on to do their investigations. Okay. All right. So why do people with Duchenne's muscular dystrophy die early? Because they get a dilated cardiomyopathy. So that's actually the most common cause of death in somebody with Duchenne's muscular dystrophy. All right. All right. So other common complications. So apart from the dilated cardiomyopathy, 30% of people have some form of intellectual disability. Okay, with Duchenne's. It's X-linked, so you can imagine that the symptoms would be affected. And the last one is respiratory. So given that you have weakness of your muscles, being unable to breathe properly increases your propensity to get chest infections. So people with Duchenne's are much more likely to get chest infections and as such. So that's Duchenne's in a nutshell. As for the management, what would you do? So it's been shown that steroids can, in some cases, decrease or slow the progression. You want to do some cardiac monitoring. So you want to get them in for regular echocardiograms. But I don't know if you can actually change the prognosis with Duchenne's or not. Okay, physiotherapy, special school. Okay, so these are all important things that you want to be saying in your OSCE. All right. So next question. We have 15. He has tenderness near the base of his thumb, and he fell over. So what is there at the base of your thumb? The scaphoid. So what do you think this is likely?
Yeah.
Okay, fracture scaphoid. So fracture scaphoid is the most common carpal bone to be broken, and it's also one of the most common. I don't think it's the most common, but it's one of the most common risk fractures that you can get. But the natural history here is very common. So what we have axial loading, okay, on a hyperextended wrist with potentially some radial deviation. So that is how you get a fracture of your scaphoid, is if you have these three things: axial loading, hyperextended wrist, and some radial deviation, which is likely what he had when he put his hand out in front of me when he was falling over. Okay. Now the other thing is that what are we worried about with a fracture scaphoid? AVN. And why do people get AVN? Exactly. So because we have retrograde blood flow from what? Which artery? From radial artery. Okay. So because it's retrograde, it doesn't have its own dedicated blood supply. So especially dependent on which part of the scaphoid is fractured, you can have somewhere from the realm of 30% to 100% likelihood of having avascular necrosis. So having, I can't remember, I don't know what it translates to, but something like the fifth part of the scaphoid has 100% likelihood of having an avascular necrosis. Okay, so how would you manage someone that had a fractured scaphoid? Anybody? What would you do? What's number one? So he comes into, yeah, sure. So analgesia, okay, orthopedics, what else? X-ray, immobilize, okay. And what is your definitive treatment? Let's say if we have an undisplaced scaphoid fracture that is simple going through the midline, what would you do for them? What would be a definitive management? So a thumb speaker. Does anybody know what a thumb speaker is? So it's essentially just like a small cast or a small plastic thing that you can use to immobilize that joint. But if it was dislocated and if it was not communicating properly, what would you then do? Anybody? Yell it out. So how do orthopedic people usually fix bones? Fixation and what? So RF, okay? So open reduction, internal fixation, or you could do a percutaneous screw, Okay, I don't know what the actual indications for each one are. All right. So next one, we have an 8-year-old. He's come to the ED, deformed arm. Okay, important. Fall from the rollerblade. So what do you think they have? Okay, so we have one option. What else could it be? Fracture radius. Do you think it could be a scaphoid? No. Do you think it could have osteosarcoma? No. A pulled elbow? Unlikely. Okay, I mean, it's an axial load rather than anything else. A subperiosteal abscess. What is that associated with? And what condition? Yes, osteomyelitis. So what is a subperiosteal abscess? So if I drew my bone, it's when you have bacterial extravasation, then you have formation of this pus, and then that causes a little bit of tenting of the periosteum, which is what you can see on a normal X-ray. Yeah. So I assume, I'm not 100% sure what a pulled elbow is referring to, but probably that. I'm not sure what you said there. Okay. So we've got two potential differentials: fracture radius or a supracondylar fracture. Okay. So how are we going to tell it apart? The first one is the fact that he said that he has a deformed arm, not a deformed elbow. Okay. If I have a supracondylar fracture, what kind of deformity will I expect? Okay. So the deformity that you can expect with a supracondylar fracture is something called an S-shaped deformity, which is deformity at the elbow joint. Whereas in this question, it states specifically that it's a deformity of the arm, so somewhere between here and here, not of the elbow joint. Okay. The second thing, actually, well, there isn't really a second thing because it says arm.
Yeah, not yeah, but like radius is in the forearm.
Oh, you know what I mean. Okay. Oh, okay. Anyway, I'll show you this picture. So this is what you call an S-shaped deformity. So you see there's angulation this way, and then there's angulation this way. So this is a supracondylar fracture. Okay. Whereas if you had a radial fracture, right, especially if it's dislocated, so radial fracture is the most common open fracture in children. Okay, so if it's dislocated, it can cause significant and very grossly obvious pathology of the arm. Okay, so apart from that, there's nothing else that I can think of that will help you to differentiate between a fracture radius and a fractured supracondylar or a supracondylar fracture. So that's the best I can offer you.
But you're saying it's a fracture radius?
Yes, it is a fracture radius. It's not a supracondylar fracture.
I just interpreted this as like a fall on outstretched hand, because that's one thing doing fall.
But the thing is that a fall and outstretched hand is a mechanism for many different things. As we found out, it's also a mechanism for a scaphoid fracture. So it's not just specific for a fracture for a supracondylar fracture.
I thought you're most likely to get like a collis fracture. It's a fracture radius, isn't it? Often at the wrist.
You can have a mid-shaft radial fracture.
I mean, you can.
Questions about I'm so confused.
I thought supracondylar was the most common fracture.
You might, I can't offer much more apart from this. I'm not sure. Well,
Fall from standing height.
Well, they were on the rollerblades.
It's not that much higher.
Okay.
What is the answer?
The answer is fracture.
Okay. All right. So I'll try and find out more. Like I said, this week I didn't have as much time to prepare, and I'll come back to you with a proper answer. Okay. Okay, same question. All right. What do you guys think of this? Tension. Okay. So tension headache is the most common pediatric headache, 50%. So 50% of people will complain of that, and only 25% of people will complain of that. So there are some very strong differentiating features. Okay. One of them is the fact that a tension headache is not pulsatile. Okay. Whereas somebody with a migraine will complain of a pulsing headache. Okay. And they'll also have, your photophobia. They'll also have your phonophobia. They might complain of some neck stiffness. And also with tension headaches, they'll also complain of end of the day, which are all features that are present within this question. Okay. All right. So now on to our next question. So I haven't provided you with the options yet because it's very long, but I think we should be able to logically get to the answer anyway. So we have somebody who's 34, primigravid, so first pregnancy. They have GDM because they had an abnormal glucose tolerance test at 28 weeks, which is the normal time to do it. Monitored her blood sugars, adjusted her diet as recommended, which is important. She's 30 weeks, so that also is important. Okay, so at 28 weeks, she was picked up to have GDM. Currently, she's 30 weeks, so there's been a 2-week period in which she's been trying diet therapy alone, diet and exercise, and that is the length of time that we need to see if diet and exercise alone is going to be effective therapy for someone who's GDM or not. Does that make sense? Because after 2 weeks, then we can consider whether to start any other medication therapy or not. Currently 30 weeks, 32 centimeters. Is that concerning? Not really. Her blood sugar levels are checked. Okay. So to diagnose GDM, what do we need the fasting blood sugars to be? What do they need to be above? Greater than 5.1. Okay. And then for any of these, what do they need to be? What do they need to be above? For
What do you mean? What do you mean?
For GDM. For GDM.
Oh, okay. I thought it was like 10
No.
or 11.
Well, yes, okay. But there's a difference, okay? So if it's after 1 hour, then it needs to be greater than 10. If it's after 2 hours, it needs to be greater than
8.4.
8.5.
Oh.
But any random measurements, fasting blood glucose is not going to change. So these are all of your this is how you diagnose and with GDM. Okay. Doesn't really matter because your body should be able to naturally regulate your meals and release the appropriate amount of insulin regardless. Okay, so that's high, and that's high. Okay, so we've already diagnosed her with GDM. So in this case, what management would you institute in her? So I'll give you a few options. Metformin, we'll use glycoside, we'll use insulin, or we use diet. Which one would you choose?
Not that. That's already fine.
Yep. What else is there? Would we choose metformin?
No.
No,
Why not?
I just don't think you do.
Okay.
You
Would we choose glycoside or glibenclamide? Second line. Would we choose insulin?
Yeah.
Okay. Now, why do you guys say we wouldn't choose metformin? So that is not correct, okay? So metformin has had its safety confirmed by the gestational diabetes study, which was a very large, I believe, multi-center study that showed that it was safe to use in pregnancies, okay? So in international countries, that is still often used as first line after lifestyle intervention for GDM, especially for women who are obese, or if they don't want to take insulin, or if they're already on large doses of insulin. However, metformin hasn't been approved in Australia for use in GDM. Okay, if somebody has pre-existing or has pre-existing diabetes and they were already on metformin, that might be an indication to continue the metformin. You wouldn't necessarily take them off. Okay, but you wouldn't institute metformin as initial therapy in GDM because it hasn't been approved in Australia. Very similarly, glibenclamide has not been approved for use in Australia as well. The reason for that is given something that acts on the pancreatic beta cells also puts the fetus at exposure to that. So you can cause some glycemic changes in the fetus, which is not safe. So you don't use that medication either. As for insulin, so insulin is used and it is recommended for use, especially in women, for example, who are type 1 diabetic or people who have insulin dependency. Insulin is very important. Your insulin requirements typically increase during pregnancy due to your physiological release of pro-diabetogenic hormones, okay? But as soon as you give birth, within, for example, the first 2 days, your insulin requirements go back to normal. The reason for that is those placental hormones that were pro-diabetogenic have a very short half-life. So once they're removed from your circulation, you then go back to your normal insulin requirements. All right, so the correct answer is yes, you would give her insulin. All right, so we have a 36-year-old
Why would diet be insufficient?
because she's already trialed it for 2 weeks. So she was diagnosed with GDM at 28 weeks. Then she came to you at 30 weeks. So there's already been a 2-week period where she's been trying diet and it hasn't worked because this is your repeat blood tests.
So you wouldn't look at like the average.
No, you only need, I believe, either 1 or 2 values that have to be above to be diagnosed. Okay. So 36-year-old, she's been pregnant, given birth before. 26 weeks, it was abnormal. She adjusted her diet, blood sugar was controlled. Currently 37 weeks, and symphysis of fundal height is 40 centimeters and is greater than the 90th centile. Okay. AFI is that abnormal? Okay.
So it's more than 20.
Okay. So this doesn't really matter. Okay. What matters is the fact that she has macrosomia in the setting of having GDM. Okay. So having macrosomia in the setting of GDM, what do you have to do?
Get it out.
Okay, you need to give me more specific answers.
What are the options?
It's either 38 or 39.
So imagine you're in an OSCE station. What would you say? What does this lady require? So she does require an induction of labor when? At 39 weeks. Okay. So for a lady that has macrosomia and GDM, you have to counsel them on doing an induction of labor by the 39-week mark because of the increased risk of having birth trauma, as well as some other things that I will remember and tell you about soon. Okay. For other cases where they don't have GDM and it's just a large for gestational age, you don't necessarily have to do an induction of labor. But in the setting of having GDM, you do. Okay. So doing the induction of labor is not indicated in fetal macrosomia alone. If you have GDM, it is. So that's why for this lady, you would need to do an induction of labor at 39 weeks. All right. Oh, yeah. So having an LGA baby increases your risk of having things like cerebral palsy. And when you have GDM, that risk is further increased, which is why you need to do an induction of labor. I'm not sure why it helps, but also birth trauma. So those answers were, so we wouldn't use an oral hypoglycemic. We'd use insulin for the first one. And then the second one was, there you go, induction of labor at 39 weeks. So that is based straight off prompt, which is why I always recommend you guys to try and look at the guidelines for any question. Looking at the guidelines will typically always give you the answer. And if you look at the prompt guidelines, they'll tell you that GDM and macrosomia is an indication for induction at 39 weeks.
What is that?
Sorry?
Yeah.
It is recommended bi-weekly CDGs. She goes or reaches 42 weeks. So this would likely be someone who had like delayed labor. So if they had post dates pregnancy, so if they're already 40 weeks and they still hadn't given birth, then by 42 weeks you'd have to deliver the baby.
5 weeks. That means
Twice a week. So twice a week CTG. Because the risk with that, having a post-term pregnancy, is 1, birth trauma, and second is stillbirth. Okay. Oh, actually, before we go into that, let's talk about management of GDM in an OSCE style. Okay. So imagine I am a lady with GDM. You're the OSCE. You're the person in the OSCE, and I tell you how you're going to manage me. What would you say? Okay. First of all, so I'm the GP. What are you going to do?
Tell her the diagnosis.
Okay, we'll skip that. Okay. Remember, referral is always important in any OSCE session. Who are you going to refer to?
Diabetes educator.
Yes, diabetes educator. Dietitian. Yep, perfect. What else? Okay. 2. What are you going to teach me?
how to do repeat blood tests.
Yes. Okay. So BGL monitoring.
Wouldn't that diabetes education do that?
Well, these are OSCE session. You need to say everything. Okay.
You say what do you know about diabetes?
Okay. We know all of that. Okay. So diet. Okay. So diet for 2 weeks. Okay, and exercise. Then we would consider starting insulin. Okay, but how about if at the time of diagnosis the fasting blood glucose was greater than 7? What would we do straight away? No, we start them on insulin. Okay, because that's over diabetes. Okay, so if you have a fasting blood, you should look at the prompt document because it has all of these diagnostic criteria on it. But if your fasting blood glucose is already greater than 7, that's an indication for starting insulin straight away. Okay. Now, if somebody already has diabetes, so they have pre-existing diabetes, you should aim to have BMI less than 27. So this is someone with pre-existing. I'm sure this is all over the place. Okay. You need to start folic acid. Okay. So again, this is somebody with pre-existing diabetes, whether it be type 1 or type 2 diabetes. So decrease your BMI, start folic acid, 4 milligrams, remember? Okay. We need to do anomaly scans at 20 weeks. Okay, anomaly scan, because they have increased risk of things like neural tube defects, of having renal abnormalities, having limb hyperplasias. So that's why we need to do that. Okay. And we need to aim for tight BSL control. Okay. And then let's say, how about for the birth plan? So we've talked about it. We need to consider whether we need to do an induction of labor. So there's a lot of things you need to consider for GDM, for any of your women's topic, for any topic in 4th year, really. So just think about it clearly and write it down, because your OSCE station will not give you good marks if you just tell the definitive management. So if you just told this lady you need to start an insulin, you wouldn't get all of the marks. So I guess what I'm trying to get at is that in an OSCE, good students will be able to answer the question, right? But the best students will be able to answer the questions and understand the limitations of an OSCE station. So they will understand that an OSCE station, you're not in front of a real patient, and you need to kind of think outside of the box. You need to imagine yourself as the GP, and in those situations, they will be able to give you those kind of answers where they talk about referral, where they talk about home monitoring, and all of those kinds of things. So try and put yourselves into that shoes.
So for that one, were we saying we diagnosed it at the 28 week point, or was this like
Which one?
just that scenario?
This one?
No, just we were saying explaining GDM. Explaining it is.
Well, yeah, I mean, if they have an OGTT that is elevated, then they do have GDM, and you would be explaining at that point. And at that point, you'd be instituting your diet and your exercise therapy, and you'd be telling them that if your blood glucose does not come down by the 30 week or by 2 weeks later, then we need to consider whether we need to start you on insulin or not. And you also refer them to all the things that we talked about.
Is 5.1 the target, and then 7 is when you actually.
No, so anything above 5.1 is a diagnostic for GDM. Okay, so you need to have a level below that. For normal diabetes, for type 2 diabetes, then yes, what you're referring to is your like your aims, right? So when you actually have been diagnosed and when you're on therapy, your aim should be below 7, but that is not always achievable. But having an elevated blood glucose more than 5.1 is diagnostic of GDM, okay, which is different from your monitoring requirements. All right. So next one. So going on to our controversial things. So 22-year-old, primo-gravid, 26 weeks, comes to the ED, sudden onset severe breathlessness. Again, okay, what are our red flag conditions with somebody with sudden onset severe breathlessness, regardless of the age? What was it? PE, what else? AMI, what else?
Anxiety.
That's not a red flag. What else? Pneumothorax, what else?
Tumor lysis.
No. Shock, what else? Anaphylaxis, oh, I guess that comes under shock. What else? How if they had recent surgery, recent cardiac surgery? Tamponade. But again, all of these come under shock, right? So tamponade would be an example of an obstructive shock, and anaphylaxis would be a distributive shock. But just think about it. Just always remember what your red flags are. Okay? Rapid breathing. What does she have? Rapid breathing. Sinus tachycardia.
This one's a PE.
This is definitely a PE. Okay. So the question is asking us, which of the above interventions, it doesn't matter whether it's investigation or management, will be most crucial initially? Okay. VQ scan.
No, that's the next.
Okay. ECG.
We have the tightest.
Just X-ray. Okay. D-dimers.
Useless.
No, for the rest of the ones on that column.
Anti-tenate.
Same time.
No. Start a therapeutic dose of low molecular weight heparin. Maybe. Okay. Prophylactic dose. Maybe. Warfarin. Yes. No, I'm kidding. Okay, so definitely therapeutic dose. Okay, it's not a prophylactic dose. Okay, just get that out of your head. So prophylactic doses are used for prophylaxis, right? Okay, so prophylaxis. So in which situation where would we use prophylactic heparin?
Like after it's resolved.
No.
Oh,
No.
Previous.
Yes. Okay. Yes. Good. Previous. But what is it? What is a clear indication for any lady that is going to give birth, a specific type of birth? What type of birth am I talking about? Caesar. Okay. C-section. So C-section. Well, I don't know if it's astronomical, but it significantly increases your risk of having a DVT/PE. So we need to give them a prophylactic dose of heparin for how long? Anybody know? So for 5 to 7 days. Okay. All of these facts are from the directly from the guidelines. Okay.
5 to 7 days
Past, after. Okay, after the surgery, after a C-section, post. Okay. Now, if the woman is an increased risk patient, so she's had a PE before, maybe she has a cancer diagnosis before, maybe she's particularly old, what would we do? No. So we'd continue. Okay. So we'd continue the low molecular weight heparin for. Yes, after C-section. Continue for 6 weeks. Okay. So if they're high risk. Now you can use either low molecular weight heparin, or you can use warfarin. I'm not sure in which situations you choose one or the other. Neither of them affect your breastfeeding. Okay. Now, before we go on to that, now as for prophylaxis, so you did talk about prophylaxis. So before surgery, for example, if a patient has a medium, low, or high risk, then you'd want to make sure that they mobilize during pregnancy. This is always the first thing they talk about is the mobilization and getting them to be active. Mobilize, so pre and post surgery. Wait, heparin. Yes, TED stockings. Okay. So you want to use TEDs? Okay. Okay. Now, how about if a patient? How in this case, right? It's quite clear that this patient had a PE. How about if we had a lady who's complaining of some uncertain chest pain? She only has slightly elevated heart rate, so we're suspicious of a PE. In that case, what would we do? No. No. Chest X-ray. Okay. So this is a good. Actually, let's answer the question first.
Is that more to rule out like everything else?
Well, we're going to talk about it after we answer this question. Okay. So that was for prophylaxis, and now we'll talk about actual investigation. So which investigation is likely to be most useful in identifying the diagnosis? So we think the diagnosis is a PE. So what are you going to do? Okay, so VQ, we have one. We have a chest X-ray. We have a D-dimer. We have a CT. That's probably referring to a CTPA. Which one would you choose? Why not a CTPA? It's not contraindicated in pregnancy.
Yeah, I've seen it.
Faculty last year told us.
It's not contraindicated in pregnancy. So which one would you choose and why? No, okay, VQ scan is correct. Yes, okay. So less radiation. So a VQ scan has been shown to deliver less radiation when you're using it in the chest region to both the mother and to the baby. So somewhere in the range of like 1 to 1.7 milligrays or something, whereas compared to a CTPA, it's more like 3 to 5. So it's a lot better for the mother. Now, that is going to be most useful, right? Most useful. However, how about if they said initial? What would your answer be?
Chest X-ray.
Chest X-ray, okay? So if you go through your flow diagram, the way that you choose what investigation to use, first you do a chest X-ray, okay? If the chest X-ray is clear, then you move on to doing a VQ scan. So that's how it works. And the reason it's better is because it has lower dose of radiation to the mother and to the fetus. Now, how about if we just had a normal patient, right? We had a normal patient and they have been complaining of some calf tenderness and some calf pain, and now they're coming short of breath. What would we need to do? So it doesn't really matter. I'm not sure, but what I was trying to get at is you would consider doing a lower limb venous ultrasound. Okay, so for somebody that has a DVT, a lower limb venous ultrasound is usually your first investigation to do, but you don't do a lower limb venous ultrasound in pregnancy. The reason for that is it's very unlikely for the PE to have come from your deep veins in pregnancy. I'm not sure where it comes from, but according to the guidelines, you don't do a low limb venous ultrasound. The other thing is that you do not do a D-dimer, okay? D-dimer is never done, especially for a pregnant female. The reason for that is that the D-dimer levels physiologically go up in pregnancy, and then yeah, okay. So you treat the condition until the diagnosis is excluded. So you do the VQ scan to exclude the diagnosis of PE, and you assume it's a PE until proven otherwise, which is why you treat it first. Okay. So also, this is from the so it was interesting. There was like 3 separate guidelines that I had to look at to get these answers. So there's the Radiology Australia the Radiology College guidelines, there was the RCOG guidelines, and there's the RANSCOG guidelines. So all of them had different things, and this one I think is from the Radiology guidelines. So if a VQ scan is available, then you use that. If it's not available, then you do a CTPA. Okay. All right. So 22-year-old. Oh my God, nulliparous, unprotected sexual intercourse, 12 hours ago. What do you give her? Yeah, so 11 legestrol. How many milligrams? What's the dose? Because you do need to know it. 1.5 milligrams.
Almost.
Close.
Okay, 32-year-old, childbirth 3 months ago, currently breastfeeding. So that's important. She's breastfeeding. She has her periods. Okay. She wants some, which is short lasting. Okay, she's short lasting. She wants to get pregnant again after another year. So what's this? So this is depot.
Because the thing with the depot is it's the shortest compared to the progesterone syndrome, but the return to fertility is quite long. So if she wants to be pregnant in a year, when she comes with the depot, she's not guaranteed to be pregnant.
Okay, so that's all very good logic. Okay, now the answer. So this remember I told you the story about how people got tilted because they read one answer on a past exam, then they used that answer for last year's exam and they got it wrong. So this was that question. So the answer to this was depot, right? But it was incorrect for last year's exam. Okay. Now, well, I think it's implanon. Okay. There's a few reasons for that. One, as Yasmin said, there's a delayed return to fertility. The second one is that it can affect your breastfeeding. The third one is that it lasts for 12 weeks, which is 3 months, with up to a 12-month period of delayed return to fertility. Whereas something like the implanon, you can insert, it has no effect on your return to fertility. It's also short-acting and it's easily removable. So it's kind of hard to decide what the best answer would be, but I will tell you that the faculty answer was a depot.
Wait, but last year it wasn't.
The last year, they didn't use the same question. It was just a very similar stem. Okay. And I don't think the question was about depot or implanon.
So if this question was exactly the same, would you recommend I just put equal?
I can't answer that question. I don't know.
Can you use the progesterone?
I got
No. Oh yeah, yes, you can, right? But because she's recently pregnant, okay, the best advice would not to be give her the POP because that is even harder to use than the COCP. Okay. Okay. So this is another question where it again highlights not to use buzzwords. Okay. So 30-year-old, yellowness of the eyes. So this is called icterus, right? She has icterus. She has tea-colored urine, so it's a little bit dark. Okay. She had pale stools, so therefore she has obstructive jaundice. Okay. So she'd been having episodic pain in the right upper quadrant. She has jaundice. Abdominal examination unremarkable. So what do you do for her? So first one, do we do antiviral agents? No. Okay. Let's start from here. Do we do a splenectomy? Do we do a splenectomy? No. Do we do a portosystemic shunt? Pancreatomy? This one? Yes or no?
Like it's
Maybe there's a maybe, but no.
Potential.
Okay.
Maybe, but probably not.
Endoscopic vesical ligation.
No.
Do we do this?
Yeah, sure, why not?
Good. Oh, well done. Why?
Why not?
Okay.
Well, what's the
Laparoscopic
problem?
How is it different to this one? How is a cholecystectomy with cholecystectomy different from a laparoscopic cholecystectomy?
Cholecystectomy is only going to take out the gallbladder. Cholecystectomy is going to take out the biliary as well. So if there's any gallstones in it, then that's going to take out as well.
Exactly, very good. Okay, so that's exactly right. So a cholecystectomy is something that you do through ERCP, right? So an ERCP approach to remove those gallstones usually within the common bile duct that is causing your obstructive jaundice. Okay.
Wait, are you taking out the bile?
No,
Or
she's
are
taking
you
out
just
the tree.
you're just cutting your
You're just
nose?
taking the stones.
Yes,
out.
it's the stem.
Yeah.
No, okay, but the thing is that a cholecystectomy through ERCP, which is removal of stones, also has a cholecystectomy following it. Okay, and usually with a cholecystectomy, you typically take out either the cystic duct, and you can sometimes take out other ducts, but cystic duct definitely. So cholecystectomy is important because a laparoscopic cholecystectomy does not insinuate that you're going to do an ERCP and that you're going to remove the stones. It's only removal of the gallbladder, so you still have problems.
45. Wait, which domain is this? Oh, is this bio?
Yeah.
Oh.
So blueness around the umbilicus, abusing alcohol for 25 years, caput medusae, splenomegaly. What is going to help him?
Shunt.
That's the only thing that's going to help him here. Okay.
That's even relevant.
Newborn.
Okay. All right. So 25-year-old, she has a newborn baby, which implies she's potentially breastfeeding, or at the very least, her breasts are lactating. She has a tender mass in her left breast, so it's unilateral. And she has a node, which is also tender in the left axilla, so she has some lymphadenopathy. So does she have fibroadenoma? No. Does she have fibroadenosis, which is fibrocystic disease?
No.
No. Does she have carcinoma?
No.
Breast abscess?
Yeah.
Yes. Does she have a galactocele? No. You wouldn't be painful and you wouldn't get lymphadenopathy. Does she? So the lymphadenopathy is likely secondary to the fact that she has an infection. Why is she getting infected? Because she's breastfeeding, one. Second, she's getting mastitis, second. And then a rare complication of mastitis is breast abscess. Parasitic cyst, unlikely. Not a phyllodes tumor, not dactylopapilloma. So it's that. Okay. So an older woman, she has a hard mass, it's mobile, and there's no nodes palpable. What does this woman have? The most appropriate diagnosis? So it's a cancer until proven otherwise. Okay. All right. So talking about breast problems. Okay.
How many questions?
We're only going to do 50. Not all. It'll be quicker. Okay. Maybe we won't talk about it then. We'll talk about it next time. Okay. Anyway, this is a localized section of erythema, which is mastitis. This is cabbage leaves that you use as therapy for breast engorgement. Apparently it helps. The coldness helps people with breast engorgement. This is nipple fissuring that happens as a complication of breastfeeding.
What chiropractic pseudoscience is this?
And then this is another picture of breast engorgement. Okay, so yeah. Well, you can also get everything with breast engorgement. Well, you can also, it could potentially be mastitis because you have a localized area of erythema. But what I was going to talk about,
Wait, can you go back?
Is that a question?
What did you say that was?
So this is either mastitis and or breast engorgement. But the thing is, breast engorgement can be a low-grade mastitis anyway.
Can't it just be like?
Potentially, I guess. Okay. So maybe. Okay. What we will talk about, one thing is. Okay. Maybe we'll skip that. We'll talk about this. Yes. Okay. Lump, left breast, 4 centimeters, firm and mobile. So that's the important part. It's mobile, and the fact she's young. So this is. So what would you do?
Go home.
Chop it.
So this one, right? No further treatment. You just need to excise the lump. Yeah, 4 centimeters is quite large.
Yeah.
Okay. 38. Lump in the left breast is 4 centimeters. It's hard, it's irregular, and it's mobile, and the axilla is clear. So what would you do for her? Okay. So there's two things. So first of all, we have a modified radial cystectomy. We have a total mastectomy. Which one would you choose?
Modified.
Yeah, so you wouldn't do it.
And
You wouldn't do a total. Okay. Would you give her radiotherapy and chemotherapy?
Probably.
Okay, so we're definitely going to exclude that one. Okay,
Wait,
so we're not
We
going to
don't
do that
know
one.
from the stem whether there's like local invasion. Like we know that there's no like lymph, like it hasn't gone up to the axilla, but we don't know if it's like more than just that left one.
Which one would you choose?
Like so, I would not just like I would have like chemo or like radio after whatever.
Okay, but would you do just radio, just chemo, or both?
What's
Okay.
the indications for either again?
So you do both. Okay, and we'll go through it. Okay, maybe we'll do it on this slide. Not that one. All right. Breast cancer. Okay, so when to use chemotherapy. Now, again, this is all really hard to actually, to form guidelines or to give you specific facts for, but I'll try my best. Okay, so an indication for using chemotherapy is one, spread. So spread to the lymphadenopathy or any signs of Mets, right? Is what I'm trying to get at. Number one. Number two is there is no clear size margin, but you become worried when the tumor is more than 4 centimeters in size. So she's definitely on the borderline for that. Okay. 3, if she has any hormone receptors positive, so that could either be estrogen, progesterone, or HER2. So if any of those hormone receptors are positive, you use chemotherapy. The 4th is if she has any kind of genomic abnormalities. Okay. And that's really all. Okay. Radiotherapy. So 1, you use it as an adjunct to partial mastectomy. Okay. Now the reason for that is it has been shown that if you do a partial mastectomy and you do radiation on top, it has been shown to have as good of an outcome as total mastectomy. However, there is an increased risk of having recurrence. So another reason that we do chemotherapy is to decrease the risk of having recurrence. Okay, so that's 1. Number 2 is any time after a total mastectomy. All right, so that's really all. So and now the other thing we need to talk about is doing the wide local. So that's really what a modified radical mastectomy refers to, is having a wide local excision. Have you guys ever heard of this? So if any of you have ever been on Gen Surg and you've seen breast cancer patients, it's pretty much always the same. You do a wide local excision, you do an axillary lymph node biopsy, you potentially do a sentinel lymph node biopsy, you send that tumor or you send that thing you've cut out down to radiology to see if you've cut it all out. You send it to pathology to do a biopsy to see if you've got clear margins or not. You then consider whether you need to do radio or chemotherapy. So it's pretty much always the same. So in the situations where you do a total mastectomy, okay, there's very few. So one of them is definitely if you have metastatic disease, you can't do just a wide local excision. Second is if she's ever had any past radiotherapy, not chemotherapy, just radiotherapy. If she has a tumor mass more than 4 centimeters, then all of these would be indications to do a total mastectomy. So in this question, what we have is 1, she has potentially increased risk of recurrence. The reason for that is because she's premenopausal, okay? So any lady who's premenopausal has increased likeliness of having more aggressive disease. So any lady who's premenopausal, you do need to give chemotherapy and or radiotherapy. So that's 1. So we've got 1 indication there. The other indication is that she's lying just on the border of more than 4 centimeters. So does she need radiotherapy? Well, likely yes, because she's had a partial mastectomy. All right. And having a partial mastectomy increases your risk of recurrence. So that's why she needs both, rather than just one or the other. Does that make sense? Okay. So that's why we choose that one. All right. Now, this is a very interesting question. So 19, low-grade jaundice, urine is more yellow, stool is normal. So stool is normal implies what? That it's not obstructive. Okay. Small mass is palpable in the left hypochondrium. What do we have in the left hypochondrium?
Spleen.
Spleen. What else? Kidney. Not kidney. Yeah, stomach. What else? Lymph nodes. What else? Yeah, lung. Potentially, if it's extending down far enough. That's a pretty reasonable list. We might also put pancreas there. Okay. So the mass moves downwards and to the right with respiration. Spleen. So what is a classical thing on the abdominal examination that we always look for? To see if the spleen moves downwards and to the right. So acute hepatitis, so look, that's on the right side, 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 that's potentially on the left side, that's on the right side, that's on the right side, and this is on the left side. So the only one that it could be is hereditary spherocytosis. So what is hereditary spherocytosis? Okay, so it's an abnormality of your red blood cells, so it causes a deformation. So what is the definitive management for hereditary spherocytosis? It's a splenectomy. Why? Yeah, so it increases your red blood cell survival. Okay, so it's been shown to increase your hemoglobin levels and also change your MCV and MCHC scores as well. So hereditary spherocytosis, because she's got splenomegaly at the moment, which is why you can feel this palpable mass in her left hypochondrium. Okay. All right. So the jaundice is due to premature death of the red blood cells, which causes the jaundice. Okay, so that would be your pre-liver. What do they call it? Prehepatic jaundice. Okay. So for this question, so the way that you find the answer to this is by doing the GP Moodle quizzes. Okay. So hepatitis A. Yes. Okay. So hepatitis A is the most common traveler's infection, which is why everybody's recommended to get hepatitis A. Meningococcus, when would we give that? Somebody who's going to Hajj. Okay. The pilgrimage to Mecca. Right? Okay. Yellow fever, who do we give this to? So Africa, if we go to Latin America and Africa, Latin America, and there's another one I can't remember. Asia, yeah, Asia. And the last one, there's another. So these are your communicable diseases that you need to vaccinate against. So hepatitis A is one, yellow fever is another one, and there's another one which I probably wrote down here, I guess. Which one? I missed all of it. Yes, typhoid. So typhoid on this list. Okay, so typhoid. So typhoid is this one. Okay, yellow fever is certain parts of South America. Okay, so South America, this person is going to Peru. So he's going to South America, so he needs a yellow fever vaccine. All right. All right. And this one, so this one's important because this one is required by the World Health Organization if you're traveling to those endemic areas. Yeah. No, sorry. Latin America, so Africa, Latin America, Asia was for typhoid. Okay, yellow fever is for South America. Oh, it is Latin America? Okay, so South America plus Africa again. Okay.
Is Latin America more middle?
I didn't even know Latin America existed, to be honest.
Why do I need to know geography?
Sorry?
Why do I need to know geography to like 2 minutes?
Well, it's on the GP Middle quizzes.
The countries are. Yeah, just like, you know, what is this?
Okay, so we have a very old person who's presenting with confusion and altered behavior. Okay, female, they live in a nursing home. She's had some abdominal pain. She's becoming more disruptive. She's constipated. So what would you do? Nothing. Absolutely nothing. Okay, I'm just gonna do this. It's very important that I do that. Definitely no investigation. You just need to manage your constipation. Okay, so this is a 54-year-old, tiredness, obese since being a teenager. Therefore, what do you expect? So all of these are elevated. So she has non-alcoholic. Okay. Increasing obesity, stretch marks. Therefore, she has Cushing's. She's 40. She's 40 years old.
Well, what do you have against people getting pregnant at 40?
74-year-old. They're presenting with some aching discomfort in the neck and shoulders for 3 months. Yes, so the ESI is very high. So she has polymyalgia rheumatica. So there's only a few things that can cause a very, very high elevated ESI. What are those? PMR. Not just multiple myeloma, so any kind of globin disease. So anything that increases globin. One of them, which is multiple myeloma. Yeah. So another one is Waldenstrom's, PMR, and what else? Temporal arteritis. Okay. So low back pain, stiffness,
Next.
angstbon. Yes, okay. So what are the complications of angstbon?
Oh,
6A.
electrical exercise.
So if we go down,
Anterior 6 days.
so
Yeah.
okay,
Anterior. Atlantic exercise. Atypical fibrosis. Aortic fibrosis of the apices of the lungs.
what would go higher? Anyway, I'll put it.
What if?
What was that?
Mitral valves.
Is it aortic stenosis?
Aortic regurg.
Yeah.
Regurg. What else?
Achilles tendonitis.
Yeah, it's
And what happens here? So this,
Yeah.
IBS. No,
Yeah.
autoimmune, like
Yeah.
that stuff.
yes, autoimmune bowel disease. So these are all complications of angstbon.
Yeah.
All right. All right. So these questions on the exam paper came right after another. Okay. What is important to remember is always use your evidence base, because after a SABA for both adults and for children, and we'll do this in much more detail another time, is your second line therapy is always going to be a low dose inhaled corticosteroids. So the answer to both of these is budesonide. Okay. So if the child was less than 2 years old, then what would be the better answer? Sodium chromoglycate. Okay. So that would then be the better answer. But we'll talk about asthma in detail later.
Wait, so a child's less than 2 years old?
Yes. All right. So 84-year-old wife died 3 months ago.
Oh, this is like, yeah.
How sure are you about that? Okay. So depressed, right? We need to fulfill these criteria. Same, GCS plus mood and anhedonia. Is he suicidal?
I haven't read
Does he have any evidence of decreased appetite? No. Okay, we don't know. Okay. Does he have any psychomotor agitation? Does he have decrease in energy? Okay. Does he have a change to his sleep? Does he feel guilty?
Probably not.
What does C stand for? Concentration. Okay. Does he have any evidence of having any low mood? Does he appear anhedonic?
Just doesn't record it.
So therefore, we definitely cannot choose major depression as an option,
Yeah.
right? Most of your psych questions will require you to fulfill at least most of the criteria for conditions.
5 out of 5.
Okay. So what we have here is that so her daughter saw him at least 12 months ago, which means that within the 12-month period, he's been deteriorating, or at the very least the same. Okay. He's left several bills unpaid, which is classical of what? Alzheimer's, because you have some sort of cognitive decline. So the other important thing to remember is that when his wife was alive, she was probably masking a lot of these symptoms. So she was probably cooking for him. She was probably paying the bills. She was probably helping him to get dressed. So after he died, that is why he's currently decompensated. So he seems to think that there are people in the house who he does not know and she cannot account for. So Alzheimer's with psychotic features is much more likely than anything else. Major depression never has any does not have psychotic features associated with it, which is also important to realize. Okay. So 21-year-old, he's a hardworking, diligent, so he's a good boy. He doesn't do anything wrong. He goes out with his friends on the weekends to drink a bit too much, but he's responsible. So again, so it's unlikely to be something like schizophrenia. It's unlikely to be something like depression, where you wouldn't care about these things. Okay. So today he comes home in the morning. So he's been out all night. He has not slept, and he's saying these weird things. Flowers will bring peace to the world. So he's not Alzheimer's, right? Do you think it might be borderline personality? No. He has no evidence of having any personality traits from early adulthood. Cannabis abuse. Okay. Abuse is an important word, right? This could definitely be cannabis use, right? Rather than abuse. Abuse implies that there's some kind of disorder or it's affecting this person's life in a negative way. That's an important thing you need to realize, is that with anything in psych, it becomes a disorder once it has a negative impact on that patient's life. Is it a delusional disorder? No. Why? Because it needs to be more than 1 month. Okay, 1 month of having a delusion. Is there a drug-induced psychosis? Yes, absolutely, definitely. Okay, so he's having a psychosis because he's having this weird, unexplained psychosis, right? He's a weird, unexplained delusion, well, we're going to say hallucination, but definitely a delusion. Okay, drug-induced. What drug has he had? alcohol, right? So people often put away to the side that alcohol is a drug, but it is. So in the DSM, they change it from drug use rather to substance misuse psychosis. So the best diagnosis for this then would be a acute onset psychosis or a first episode psychosis. But the best we have here is drug induced, which definitely fits all of his symptoms, not depression and not any of these. Okay, so a 69-year-old, he's a retired builder, he's overweight, ex-smoker. He was active and busy until 18 months ago, okay, where he suffered a turn. Since then, less active, requires a lot of encouragement to attend and participate in events. So he seems to have some sort of apathy, okay? He has not lost any weight, okay? Over the last 3 months, he's become unsteady on his feet, so he maybe has some ataxia. He becomes frustrated at times when others cannot understand him, so maybe he has some sort of aphasia, okay? So 18 months, and then again in 3 months. So I would call this a stepwise decline. So he has vascular dementia. So 72, lived alone for many years since her husband was tragically killed in an MVA. So she expressed some concern to her son. So the fact that she's expressing concern, right? Remember we talked about hallucinations and delusions, and you can only define something as a delusion if you believe it for sure, that you can be sure that it's coming from externally in your mind. So we can probably comfortably say that this is potentially some sort of auditory hallucination, okay? But he found no evidence, so it's definitely not true. Her concerns persisted even after her hearing aid was checked. Why have they included this? No, because having some sort of sensory defect, or any kind of defect in any of your senses, whether it be taste, whether it be vision, is a risk factor for having delusions. Delusion. Sorry? No, delusions. So that's a risk factor. So having a sensory defect is a risk factor for having delusions, and it might have been the delusions and I think it might be hallucinations rather than delusions, but one of them. Okay, so it's a risk factor. It's a known risk factor. So she seems to have accepted that, but instead is convinced that she has seen through the kitchen window children in Halloween costumes. So it's a well-formed visual hallucination. So she potentially also has query visual hallucinations, climbing up the drain pipe, presumably to access the roof space. Okay, so amnesitic syndrome, no. Do you think she might have Alzheimer's? There is no evidence of any cognitive decline. Do you think she might have dementia with Lewy bodies? Okay, what makes it very unlikely? There's no, okay, 1, there's no neurocognitive defect. 2, there's no ataxia. 3, there's no Parkinsonian symptoms, etc., etc. So to diagnose Lewy body dementia, you need to fulfill certain criteria, more than 2 out of 5, which we talked about last week. So in this case, she wouldn't be filling in any of these. You might say she might be having Lilliputian hallucinations because she's seeing children in Halloween costumes. However, as we talked about, you need to fulfill more than 1 criteria, and you need to go on more than buzzwords. So it's unlikely to be dementia with Lewy bodies. Frontal lobe stroke, she has no acute symptoms, no behavioral changes. Hydrocephalus, no. Hypothyroid, no, not that, not that, not that. So do you think it could be this? Okay. So she's fulfilling H. She's fulfilling D. She's fulfilling the other D, which is a disordered thought. Okay. Maybe she might not have disordered speech, but who knows? She's not having negative. Well, she might be having negative symptoms because she likes to stay home by herself. So at the very least, she's got more than 2 out of 5 for late onset. Now, late onset itself is a very rare diagnosis. However, it is common in elderly people who are living by themselves and who have some sort of sensory defect. So it's a difficult question. A lot of people did go with dementia with Lewy bodies, but as Yasmin said, there is no other feature that will suggest it. So what I'm trying to tell you is make sure you try and find what the criteria are in the question and try and fulfill it. Okay, what do you think this man needs? So 32, he's lost his job. He's got some depressive symptoms, and he's worked there for a really long time, but he's questioning whether he's actually capable. So what do we call this? So this is a maladaptive thought, right? And how do we fix them? CBT. Okay. So this person is 45, has been in bed for 3 weeks since she froze in the shopping center, suddenly felt that everyone was staring at her, expected her to faint, could not ask anyone for help. So it's severely affecting her life. And she's not sure how she got home, but has been terrified to go out again if the same thing happened. What does she have? You could very comfortably say that this is agoraphobia. what would be the most reasonable for her?
Meds.
Yes, meds, escitalopram, because it's causing such a debilitating effect on her life at the moment. It's better that you give her some medications before you go on to non-psychological therapy. Okay, so David, he's 72, found by his daughter with a noose hanging, so he tried to kill himself. All right, because his wife died. He also has prostate cancer, so he has very poor prospects. He says that he did not know what else to do. Okay, so I mean, none of that's going to help, so we'll just cross that out. We'll talk about two things that are likely: crisis or admission to hospital. What do you think?
Admission.
And what's his suicide risk?
He's acutely suicidal, right?
Yeah.
So he's just tried to commit suicide. Okay, he doesn't regret his actions. He doesn't know why he did it, which means that he potentially hasn't developed that guilt. He potentially might still have a plan in place. He has some significant biological and psychological risk factors with the death of his wife and him having cancer. And crisis intervention does not necessarily guarantee him admission to hospital because he has high risk. So risk of committing suicide, you need to make sure that he's not going to acutely cause harm to himself or harm to others. So you need to admit him. Okay. So this is a foot drop. What causes a foot drop?
Common perineal.
Yeah. Not lithium. Okay, so this man has angstpon. Okay, and people with angstpon, 90% have a positive HLA. Okay, none of these are going to be specific, right? All of these can be increased by something else. But angstpon has one of the highest rates of having a positive HLA associated with it. Other things are things like Reiter syndrome, which is like 85%, but still angstpon greater than 90%, so it's very, very important. Not Reiter's, the one that's caused by sexually transmitted infections.
That is right.
Yeah, Reiter syndrome. Yeah, Reiter syndrome.
How does that have HLA?
I don't know. Okay. Oh, we've done this. Okay. So 72-year-old chronic ulceration, right? Chronic ulceration on the lower third of his leg. All right. He's been bleeding lately. There's a region of ulceration on the medial surface of the left shin, which is quite large, gray adherence layer, edges are heaped, and it bleeds easily, so it's very friable. Okay. Now, look at this. The edges are very uneven. Okay, so what does that make you think first? Venous rather than arterial. Okay, if it was arterial, it would be punched out and it'd be very well demarcated, so we can rule that out. Okay, venous isn't even on the list. So atypical tuberculosis, unlikely. Trauma, potentially, but it wouldn't cause that large of a region, nor would it be friable, nor would you expect it to have this kind of appearance. It looks very ulcerated. Okay, basal cell carcinoma. No. How about SCC?
What's the one that's left?
Okay, so what is this condition called? This is Bowen's disease, likely. Okay.
Wait, isn't Bowen's disease like pre-squamous cell?
What am I thinking of? SCC can go on to form malignancy, and there's a specific type of tumor that it can cause. I think it might be. I mean, Bowen's disease is SCC in situ, right? But SCC there is a name for this condition, but it's escaping me right now. It's a specific type of tumor. I'm pretty sure it starts with M.
Marjorie ulcer?
What was it?
Marjorie ulcer?
Yes, Marjolin's ulcer. Yeah, that's what I was going for. Oh, I missed what you said. Sorry.
No, okay.
So this is Marjolin's ulcer. The name escaped me. I'm sorry. Thank you very much. All right. Type 1 diabetic who's just about to undergo surgery. What is something a type 1 diabetic? 1 second. What is something a type 1 diabetic always needs?
Insulin.
Insulin. They always need the insulin. There is absolutely no situation where they do not need the insulin. So we can cross that out. We can cross that out, and we can cross that out. Okay. So we've already got rid of three options. Just before going, what was your question?
It could be like binary.
Yeah. So things like that, or erythema nodosum, which is also an ulcerative condition. It could be one of those things. Okay. So in this case, so we've identified that someone with type 1 diabetes. So type 1 diabetes always needs insulin, okay? There's absolutely no exception to that rule. What else do they need? So do they need normal saline or do they need dextrose? Why do they need dextrose?
Like if you're just giving them.
Okay, yeah, okay, that's reasonable, yes. So one, to decrease the risk of hypos, but what is a better reason? Ketones, okay? That's the most important reason. So you give them dextrose to prevent them from forming ketones, because if you don't, like you said, if you don't give them any glucose, they'll go into starvation ketosis, and they'll develop ketones, and then therefore they might become acidotic, and that will become an anesthetic emergency. So you have to prevent that by giving them something for the insulin to act on, which is the dextrose. So relatively simple question that only requires you to understand those concepts. Okay. All right. So 46 kilograms in weight loss, slow enlargement of a painless swelling over his neck, 67, 22, heart rate is a little bit high, brisk reflexes, mild tremor, there's a diffuse non-tender goiter. Graves. Okay. But what could it also be?
That's on the list.
Yes.
Toxic.
Yes. So it could also be that one. Why do I say that? I mean, a lot of people will see a toxic multinodular goiter and they'll think that you'll have multiple nodules. However, the most common way that a toxic multinodular goiter presents is as a single, very large nodule that is prevalent. So it could also present as a large swelling, but Graves' disease is still the better answer in this situation. Okay, so what's this? Okay, so 54, fatigue, dull pain, including his lower back, important left arm and right leg. So he has bony pain. Tentative depalpation. Normocytic neurochromic anemia, so he potentially has chronic disease. Chronic disease. Okay, as we can see there. ESI is greater than 100. Therefore, he has... I mean, again, I always tell you, don't get buzzed, but everything in this question suggests multiple myeloma, including his serum creatinine, okay? Because remember, our Krabs mnemonic. So what does C stand for? Increase. What's R? Rolu and renal failure. So it's more than one thing. A, anemia. What else? Amyloid. What's B?
Body pain.
Benz-Jones. Plus bony pain. And S? I was hoping you guys could help me because I could.
Isn't it? No, there's definitely an S to it.
Definitely an S.
Yeah, I said about
It's definitely splenomegaly, okay? Because, but I don't know if there's another S. Increased creatinine.
Oh, no, it's calcium.
And calcium.
Okay.
Okay. So
Yeah.
yes, absolutely. So
Yeah.
things that cause splenomegaly is congenital things, hematological, infectious, or autoimmune. Things that cause massive splenomegaly is multiple myeloma, malaria, and CML. Okay. So multiple myeloma is definitely something that causes massive splenomegaly.
Wait, also is 8 also like ALP increased? Or is that also?
No, that's, I don't know. You get them in patches, definitely, but I'm not sure about multiple myeloma. Okay. Okay. So poor balance, worse over 6 months, recent falls. It's occurred mostly during the nighttime. He's able to stand with his feet together when his eyes are open, but falls when his eyes are closed. Vestibulo-ocular reflexes are intact. So remember, we've talked about this question before. What do you need for balance? Okay, balance requires 3 things to be functioning.
Vestibular, cerebellar.
So vestibular, your visual. So remember, vestibulo-ocular is also goes through your cerebellum. Okay, visual and proprioception. Okay, so is his visual system working? Yes. Is the vestibular system working?
Yeah.
So what's not working? Proprioception. Okay, so this question is asking about calcium homeostasis, right? So what are the hormones implicated in calcium?
Sorry, was that one E?
Yes.
Yeah.
So what are the hormones implicated in calcium for calcium homeostasis in the body? Okay, so PTH, vitamin D, and calcitonin. Okay. Well, most importantly, okay. So the way I remember is phi and high. So this increases your calcium levels. Okay, so vitamin D is also calcitonin. So calcitriol. So tri and high again, so that increases your calcium, and then calcito, so to and low, so that decreases your calcium. Okay, so first one, we can based on this reasoning. So what normal? So she has low vitamin D, right? And her calcium levels are still high. So it can't be anything related to calcitonin. And PTH increases your calcium level, so therefore it can't be reduced parathyroid, right? Okay. Can it be increased intestinal phosphate absorption? Okay. So another thing PTH does is it decreases your phosphate. The reason for that is phosphate binds your calcium, so it effectively decrease your calcium levels. So not that one. Reduce intestinal phosphate, and that's a secondary effect. Okay. Renal excretion, again a secondary effect. So increased parathyroid hormone secretion, which increases calcium. Okay. All right. So this patient is very young. They're on carbimazole for the treatment of thyrotoxicosis. 2 weeks later, so very acutely, she has a sore throat, a painful mouth, febrile, and multiple small ulcers on her mucosa and palate. Okay. So what do we call this? Yes. So that's normal. So it's not pancytopenia, but she has agranulocytosis. So therefore,
Drugs.
So drugs. So this is a secondary effect of the carbimazole, is she's having agranulocytosis. There's nothing else in this question to suggest that she has a HIV infection, right? She has no risk factors for it, and there's nothing in the stem tells us that. But what you are saying is correct, is that some of the features in the stem do suggest an AIDS-defining illness, but nothing else in the stem.
Wait, it's herpes. That's herpes. That's literally.
So I'm talking about this. So there's also some features that suggest a AIDS-defining something like Kaposi's sarcoma potentially could present similarly to this, not exactly the same. Herpes again is the same, but nothing else in this question fits rather than drug toxicity.
What's the most likely cause of it? So yes, she's immunocompromised from the drug.
But the thing is that, look, if you had a herpes stomatitis, are you going to get a massive decrease in your white cell count and your neutrophils? Rather, you'd have an increase because you had an acute infection.
Like, I get it. Like I said, she's immunocompromised, so the drugs cause her to be immunocompromised. But then the cause of her presentation is cause of infection, right?
Right. Okay. Yeah, I get your point. That's true.
She's really coming with just neutrophilic.
I think in the call presentation, the herpes simplex and our question is asking the cause of the presentation.
Yeah, because you can't say for sure that it is due to herpes, but I understand your point.
I feel like either way, it comes down to the fact that they took the drug in the first place. Like,
Yeah.
I wouldn't have got that.
Yeah, definitely. Okay, so this man, protein is normal. So he's just having a insurance medical, which means that this is incidental, right? That's why they put that in there. Okay, albumin is normal, bilirubin slightly high, ALP is normal, GGT is normal, that's normal, and that's normal. Okay, alcoholic liver disease would give you abnormal liver tests. Chronic hepatitis C again would be abnormal. Gilbert's, okay? So Gilbert's can, yeah, so pain.
Okay, so with the previous question, doesn't toxicity imply it's like, does that include adverse effects, or is that like just be used too much?
It's just an adverse effect. Okay, thank you everyone. I'm sorry that took so long.
Thank you so much for all
I
that.
gotta run us, but thank you so much for that.
Hopefully next week will be Professor Orrit. Nick Orrit. You know Nick Orrit?
Not a clue.
Absolute G. Hopefully he'll take you.